Now we are moving ahead with the next awaited session, SwasthyaCON Oration. As a chairperson, I would like to invite Dr. Sushil Patel sir and Dr. Yash Patel sir. Over to you, sir.
Good evening, everyone. Good morning and good afternoon to different part of the world. As the organizing secretary, both of us, Dr. Sushil Patel and Dr. Yash Patel, myself, it's indeed pleasure to invite ourselves for SwasthyaCON Oration Award, where Swasthya is pleased to initiate the SwasthyaCON Gold Medal to recognize the achievement of those who have already contributed to society through their professional inputs, but are one on the path to do more in the years to come. It is thus not only an appreciation of the past, but also a precursor for the future. It is conceived as the annual award to continuously inspire talents and performance dedicated to community welfare. I would invite my co-organizing secretary, Dr. Sushil Patel, to introduce our Oration Award winner. I'll say Dr. Pankaj Shah for the same. Dr. Sushil Bhai, please.
Thank you, Yash, and it is my indeed pleasure to invite Dr. Pankaj Shah for the oration lecture. He's a MD and endocrinologist. He's working with the Division of Endocrinology Mayo Clinic Roster in the USA, and he's a well-known endocrinologist and very good orator. And we had heard him several times in the past also. So I would like to congratulate Dr. Pankaj Shah sir also for this oration award, and I would request Yash to join me to present the oration award to Dr. Pankaj Shah sir. And we are
Oration
presenting
award to Dr. Pankaj Shah sir.
Thank you so much, sir. Really honored.
We'll make sure to it reaches to you in a time frame that we can deliver. Sorry for at present.
No problem. Thank you so much.
So I would like to ask Dr. Pankaj Shah sir for his oration lecture.
Good evening, ladies and gentlemen. Thank you, Dr. Mayur Patel, for this invitation. I'm excited to present my topic on the changes in management of type 2 diabetes over the last decade. This is the talk layout. We will first talk about prevention of type 2 diabetes. We'll talk about simplification of treatment and then individualization of treatment based on type of diabetes, the risk of atherosclerosis, risk of heart failure, including preserved ejection fraction, and risk of end-stage kidney disease, and how has that changed over the last decade. Let's start with prevention of type 2 diabetes. We'll start with a case. This is a 66-year-old woman with pre-diabetes. During her pregnancy, she did not have gestational diabetes, has a BMI of 32, and in order to prevent or delay the onset of diabetes, what did we do in 2012? Well, we asked her to join a lifestyle program like the YMCA's Diabetes Prevention Program available in US, and I'm sure there are similar programs in India as well. In addition, we would recommend metformin. Not only that we would recommend metformin, but there were studies showing that metformin prescription for uninsured adults in prediabetes or insured adults in prediabetes was rarely prescribed. It was thought that this was safe, tolerable, evidence-based and cost-effective prescription for prediabetes, and we were underutilizing it. Let's look at some of the data. This slide shows the conversion from prediabetes to diabetes and diabetes prevention program. More people from prediabetes develop diabetes, if their fasting glucose is high, their body mass index is high, or amongst women, those who had gestational diabetes, if they had pregnancy compared to those who did not have gestational diabetes. Lifestyle intervention prevented diabetes across the board. However, when metformin was used, it prevented diabetes in those with higher starting glucose, higher BMI, younger age, and amongst women who had pregnancy, those who had gestational diabetes, but not the other groups. In addition, metformin has not been shown to be any better than intensive diet plus exercise program. In same meta-analysis, it has been shown that metformin plus intensive diet and exercise program was no better than intensive diet and exercise program only. Not only that, some recent publication from Diabetes Prevention Program outcome study shows survival in those who received placebo as shown here. The shaded area was the time when the randomized control trial continued. Amongst those who received metformin at that time. Metformin did not improve survival in the patients who received it compared to placebo. Admittedly, patients received it only during the trial period, and beyond that they were not randomized into the two groups with or without metformin. So, in order to prevent or delay the onset of diabetes, in 2022 we continue to recommend a lifestyle program, but recommend no drugs to prevent the so-called onset of diabetes. Moving over to simplification of treatment, and we will take another case. This is that of a 63-year-old woman who had acute onset so-called insulin-dependent diabetes. She was diagnosed 12 years back with significant hyperglycemia and has been on various insulin regimens since then, now on pump and sensor, with a hemoglobin A1C of 6.8%. This is her 30-day glucose and pump download. The sensor glucose data is shown in green and the insulin delivered in the purple below, and as you can see, the bolus insulin is much less than the basal shown in the dark purple area. If similar data is divided from midnight to midnight all across 30 days, the glucose concentration can be seen pretty much a straight line through the 24-hour period within the target, such that about 98% of the glucose was in the target of 78 to 180 milligram per deciliter. In a situation like this, where there has been acute onset of diabetes, well controlled, what did we do in 2012? Well, we would congratulate the patient, tell that she is doing well, and won't change anything, or maybe if she wants to go, she can go to multiple daily insulin injection plan using glargine and aspart or glargine and lispro, etc. What did we do now? Well, in 2012, there were several options for treatment, but in 2022, there are many more options now. But more importantly, there is more experience with these options. So in 2022, we saw her recognize that she had type 2 diabetes, started metformin, and then started semaglutide. Soon we discontinued boluses and discontinued basal and pump. And despite no insulin for 3 months, her hemoglobin A1C then was 5.8% and she had lost significant amount of weight. So if a person who is on multiple insulin dose plan can be simplified by adding metformin or a GLP-1 analog and continuing to use long-acting insulin, or adding DPP-4 inhibitor instead of GLP-1 analog, or adding an SGLT2 inhibitor with metformin and long-acting insulin, or switching patients completely to NPH morning and bedtime, or pre-mix insulin 2/3 before breakfast and 1/3 before the evening meal. Each one of these has some advantages and disadvantages, as has been shown in the right column. So in 2012, we would work on adherence and assess adherence and explore barriers, depression, education, socioeconomic barriers, etc., and establish a close follow-up. In 2022, things have changed. There are many options now and a lot of experience with using these agents with or without insulin. Some of these agents, of course, have additional benefits of weight loss and others that we will discuss soon. So much so that American Diabetes Association now has a whole algorithm of simplifying insulin regimen in a patient who is using multiple daily doses of insulin or complex regimen. Moving over towards individualization of treatment, first of all, based on type of diabetes. Here, we will take another case. A 57-year-old woman with diabetes since 2000 was diagnosed because she had a strong family history and diagnostic hemoglobin A1C was 6.6% with a fasting plasma glucose of 130 mg per deciliter. She was on gleburide or glibenclamide for a few days in 2016 and had hypoglycemia, so she discontinued it. She monitors glucose morning, fasting, and it is always less than 140 mg per deciliter. She is overweight and now has a hemoglobin A1C of 6.3% with a fasting glucose not very different from diagnostic fasting glucose. She has absolutely no complications. So what did we do? What would we have done in 2012? Well, we would have congratulated her. She's doing great. There is no need to change anything. But what did we do in 2022? Well, I proceeded with doing GAD65 antibodies. Excuse me. And this was negative, as one would have expected. And in this atypical, unusual type of diabetes, I looked at the history of hemoglobin A1C. That was pretty much a straight line for the last about 15 years or so. So was fasting plasma glucose in a very narrow range. Based on this, I proceeded with molecular genetics testing, and the patient turned out to have monogenic diabetes from glucokinase gene mutation. So what difference did we make? Well, in the past, she had label of diabetes. She was trying out medications, testing glucose at home, and was concerned about complications, being screened for various complications annually and blood test visits every 6 months. She was counting carbs and exercising regularly. And after the diagnosis, she has label of genetic hyperglycemia of uncertain significance. She does not need any medications. She does not need to monitor at home. And there is no concern for complications because it does not cause complications. There is no need for screening. Of course, she should continue exercising and living a healthy life. Of course, she has never forgotten sending us greeting cards on every holiday season, including the latest one, as you can see, the green one. So the implications of diagnosis of monogenic diabetes is significant. It accounts for about 1 to 3% of all diabetes. About a third to half of them have glucokinase gene mutation, which does not require any treatment because there are no microvascular complications from this. Then there are HNF mutations, HNF1A, about a third to 2/3. These are very sensitive to sulfonylureas and are better treated with sulfonylureas than even with insulin. Same is true with the HNF4 alpha mutations, very sensitive to insulin. And then there are other mutations as well. So broadly speaking, vast majority of the patients either have glucokinase gene mutation, don't need any treatment, and complications are rare, or have HNF mutations where they are sensitive to sulfonylureas and better treated with sulfonylureas. And then there are others which are often associated with certain congenital anomalies. So it is important to find the type of diabetes. This is done mostly clinically, but if needed, tests can be done, and if type 1 diabetes is found, we can switch to appropriate insulin regimen and appropriate technology, pump, sensor, closed loop, artificial pancreas. Or if it is type 2 diabetes, we can keep the treatment simple and prevent specific medications to use specific medications to prevent complications. And then if we find specific types of diabetes, for example, MODI, then we have specific treatment or no treatment at all. Or of cystic fibrosis related diabetes, we need to know what postprandial glucoses are doing to reduce risks of infection. And of course, in gestational diabetes, appropriate treatment is required to prevent long-term implications on baby and the mother. So in terms of simplifying the treatment plan, in 2012, we would try out various treatment plans. Many tests were available then, but not easily available. Now, of course, we still use clinical judgment, but because of widespread availability, better understanding of utility and reliability of genetic tests for monogenic diabetes, for testing multiple autoantibodies for type 1 diabetes, and C-peptide and fasting glucose to see insulin secretion, we can sort out the type of diabetes now much easily than we could do in 2012. Moving over to individualization of treatment based on risks of atherosclerotic cardiovascular disease, risk of heart failure, including preserved ejection fraction, and end-stage kidney disease. Let's see where we were about 10 years back. This is the data from United Kingdom Prospective Diabetes Follow-up Study. This study showed that using sulfonylurea to reduce glucose concentration was associated with decreased mortality. Likewise, using metformin to decrease glucose concentration decreased mortality by about 15 to 25%. Similar reduction has been shown in secondary analysis using pioglitazone versus placebo. Even bariatric surgery has been shown to be associated with decreased mortality. But most importantly, multiple interventions, including glucose management, has been shown to reduce the risk of mortality or cardiovascular events by about 45%. Because glucose control helped prevent complications, we tried to control glucose. But then we thought that tight glucose would be even better. And for that reason, two large-scale studies were conducted, the ADVANCE study and ACCORD study, where the target glucose in intensively controlled treated was much lower than the standard of care at that time. Despite clear differences in glucose concentration in intensive control and in standard therapy groups, there was no difference in major adverse cardiovascular events over the randomized controlled trial duration in both the studies. Actually, if anything, ACCORD study showed an increase in mortality in patients who were intensively treated. In addition, we were wondering whether insulin provision or insulin sensitization would be better in preventing death associated with diabetes. So in this large randomized controlled trial, either patients were randomized to receive metformin or thiazolidinediones, the insulin sensitization group, or they were receiving sulfonylurea or insulin. And as can be seen here, there was absolutely no difference in survival between the two groups. Therefore, we concluded that tight glucose control may not reduce cardiovascular events any further than controlling diabetes. And of course, it did not matter what medicine we used to control diabetes. Moving on to a few cases. This is a 56-year-old woman with type 2 diabetes, which is uncontrolled. She's obese, has past history of MI, has chronic kidney disease. What was our option in 2012? Well, we would continue metformin And we would possibly add one of the sulfonylureas, a DPP-4 inhibitor, pioglitazone, or insulin, intermediate or long-acting. In addition, we would debate whether hemoglobin A1C should be below 7%, below 8%, or below 6.5%. What about 2022? Let us look at some data. This is data from two large studies using SGLT2 inhibitors which cause glycosuria and natriuresis. Using empagliflozin in randomized controlled trial showed a 15% reduction in major cardiovascular events, that is cardiovascular death, non-fatal MI or stroke. Likewise, canagliflozin is associated with 20% reduction in major cardiovascular events, as well as reduction in all-cause mortality. This is similar data of GLP-1 analog, which trigger insulin release, inhibit glucagon release, decrease appetite, and slow down gastric emptying. As you can see, liraglutide use is associated with about 15% reduction in cardiovascular event, dulaglutide with another 12% reduction in cardiovascular events, and semaglutide with about 25 injectable semaglutide with about 25% reduction in cardiovascular events. In addition, exenatide seems also to show benefit which was not statistically as robust. So in 2022, well, it's not an option. It's a standard of care that the patient has risk for cardiovascular events or has established cardiovascular events. We should reduce the risk of cardiovascular events by using canagliflozin, empagliflozin, or dapagliflozin, or liraglutide, dulaglutide, or semaglutide. Though similar data can be seen with oral semaglutide and exenatide LAR, but these are not specifically approved for that purpose. Next case, this is a 52-year-old man with hypertension, congestive heart failure, reduced ejection fraction, obesity, and well-controlled diabetes on metformin. Serum creatinine is 1.2 milligram per deciliter, which gives him a GFR of 47 ml. First of all, in 2012, we wouldn't use pioglitazone or rosiglitazone in those who are at risk for heart failure because in retrospective analysis, it showed a 50% increase in risk of acute heart failure. Actually, in randomized controlled trial data, it showed almost 110% increase in heart failure episodes. In addition, metformin use with or without other drugs was associated with decreased mortality and better survival in two separate retrospective studies. So in 2012, we would continue metformin, not add pioglitazone, but add the sulfonylureas, a DPP-4 inhibitor, or intermediate-acting insulin, and then we would debate whether the target should be below 7%, below 6.5%, or below 8%. What about 2022? Let us look at some data. This is from three large studies of SGLT2 inhibitors. Once again, the agents that caused natriuresis in addition to glycosuria. And as can be seen, using these agents, there is about 20 to 35% reduction in hospitalization for heart failure or hospitalization, heart failure or death using empagliflozin, canagliflozin, or dapagliflozin. Similar data can be seen in those irrespective of diabetes. About 25 to 30% reduction in hospitalization of heart failure in those with reduced ejection fraction, even in those with preserved ejection fraction only recently published. Interestingly enough, about 40 to 70% of these trial participants had diabetes, not 100%, and there was no difference in their survival. The survival benefit was seen in diabetics as well as non-diabetics. So in 2022, what are the options? Once again, these are not options. These are standard of care. We should use dapagliflozin or empagliflozin to reduce risk of acute heart failure in those at risk of heart failure. Specifically, canagliflozin and orthogliflozin have not been approved for this purpose, but data is very much convincing to me at least. Next is a case, 54-year-old woman with well-controlled diabetes and serum creatinine of 1.5 milligram per deciliter and significant albuminuria. The patient is on glipizide, metformin and sitagliptin. What would we have done in 2012? Well, we would have stopped metformin. Why? Because creatinine was more than 1.4 milligram per deciliter. We would have reduced sitagliptin for the GFR and continued glipizide or changed sulfonylurea or stopped sulfonylurea and used various forms of insulin, either basal or premix, and then made more complex. But what are the options in 2022? Well, let's look at some data. These are 3 large-scale studies using SGLT2 inhibitors in those at risk of kidney disease. As can be seen, using canagliflozin, empagliflozin or dapagliflozin is associated with about 45% to 25% reduction in end-stage kidney disease, renal death or cardiovascular death, essentially hard endpoints. This has been shown also in people who don't necessarily have diabetes. These are studies irrespective of diabetes, and similar benefit can be seen in terms of hard renal outcomes. Once again, about 40 to 70% of these populations had diabetes, and the benefits could be seen in those people with diabetes as well as people without diabetes. This is some data on GLP-1 receptor agonists, and these agents, dulaglutide and liraglutide, have been shown to reduce progression of macroalbuminuria, though the end-stage kidney disease itself was not statistically significant. So what are our options in 2022? Once again, these are not options. These are standards of care. The standard of care now is to continue metformin because GFR is more than 30, and use dapagliflozin or canagliflozin to reduce the risk of end-stage kidney disease. Not specifically approved, but empagliflozin has similar data. And liraglutide and dulaglutide could be used to reduce the progression of proteinuria. In addition, because these people with chronic kidney disease are very high risk of heart disease, atherosclerotic disease, the various agents we had used, that includes of course these agents, to reduce cardiovascular events should at least be used. Let's move on to the next case. This is that of a 54-year-old woman with uncontrolled diabetes. Rest of the parameters are the same. What was our option in 2012? Well, we didn't have a lot of options in 2012 because we were told to avoid these because of risk of hypoglycemia, risk of lactic acidosis, volume retention, etc. So we had ultimately to use insulin in people who had chronic kidney disease. What has happened in 2022? Well, a lot has changed. We have many more options in people who have stage 4 or 5 kidney disease. Many of these agents can be used even while the patient is getting dialysis, if at all required. To summarize then, many patients with chronic kidney disease stage 4 or 5 don't require any treatment. And if they do, we can use linagliptin at the standard dose or sitagliptin, saxagliptin, elogliptin at a renally adjusted dose. We can use GLP-1 receptor agonist, liraglutide, semaglutide, both injectable and tablets, and dulaglutide. This is of course associated with weight loss, which may be desirable in some of these patients, but they have more adverse effects of nausea, etc. We can use nateglinide, we can use pioglitazone, that is often associated with fluid retention. We can use insulin, that gets complex and testing and everything else. Or instead we can use sulfonylurea. Cautiously, of course, like we would use insulin as well. If the patient is already on dapagliflozin or canagliflozin, we can continue using these agents even up to the time of dialysis. Specifically, liraglutide, injectable semaglutide and dulaglutide, or dapagliflozin and canagliflozin can be used in these patients, or should be used in these patients to reduce cardiovascular risks. Therefore, now American Diabetes Association concludes that generally comprehensive therapeutic lifestyle changes and metformin usually is the first line therapy, but soon thereafter we have to find out if the patient is at high risk of established atherosclerotic disease, heart failure, or chronic kidney disease. And if so, the treatment should be tailored. If the patient is at very high risk of atherosclerotic disease, we would preferably use liraglutide, dulaglutide, or injectable semaglutide, or use empagliflozin or canagliflozin. If the patient has heart failure, particularly with reduced ejection fraction, we should use empagliflozin, canagliflozin, and dapagliflozin. And with preserved ejection fraction, now one trial shows the benefit of empagliflozin reducing hospitalization for heart failure. If there is chronic kidney disease and albuminuria, we preferably should use SGLT2 inhibitors with the renal benefits, which are EMPA, CANA, and dapagliflozin, or SGLT2 inhibitor or GLP-1 receptor agonist with cardiovascular benefits, as shown here on the left. These should be used independent of the prevailing hemoglobin A1C concentration, the patient's hemoglobin A1C target, whether it's already controlled or not controlled, or patients is using metformin or able to use metformin or able to tolerate metformin or not. Other antidiabetic agents may need to be reduced if blood glucose is already well controlled and we are adding these agents to prevent hypoglycemia. If these are not able to control glucose, or the patient does not have the risk or established risk of these, then of course the treatment depends on whether we want to minimize hypoglycemia, attain weight loss, or consider cost and access to treatment, and there are specific pathways for that. So to summarize then, what has changed in the management of type 2 diabetes in the last decade? Well, for prevention of diabetes, lifestyle intervention remains the mainstay. We don't use any medicines to prevent so-called onset of diabetes. Now, there are many proven ways of simplifying treatment in people with type 2 diabetes. We should individualize treatment by figuring out the type of diabetes and use specific treatment by testing antibody, genetics, and figure out if the patient needs treatment or not, and if needs, what will be the best path of treatment. We should individualize based on risk of atherosclerotic cardiovascular disease or established atherosclerotic cardiovascular disease to use specific agents that have been shown to be associated with reduction in cardiovascular events. If there is a risk of heart failure, one should use specific agents that reduce acute heart failure like dapagliflozin or empagliflozin, and empagliflozin has been shown recently to reduce the risk of heart failure even in those with preserved ejection fraction for a change. And those who are at risk of end-stage kidney disease, we should use agents that reduce progression of kidney disease to end-stage kidney disease. And those with stage 4 or 5 kidney disease, there are many options other than insulin, which was the only option in 2012. Thank you so very much for patient listening.
Thank you.
Thank you, sir. You said, and we are happy to deliver this oration lecture, oration award to you. So,
Thank you so
much. On behalf of all the SwasthyaCON committee, and I request Dr. Mayur Patel sir also to have a few words.
Thank you, Dr. Shah. As ever, you have delivered a very interesting, very informative talk, and you well deserve for the oration. And on behalf of the oration selection committee, I thank you very much for accepting our invitation.
Thank you, sir. I really appreciate this honor and opportunity to see the faces on screen at least. Hopefully, we'll see face to face next year.
Thank you, sir.
Thank you.
As it is oration lecture, we are not having any question answer. So we are moving ahead to the next oration.